All right, let's go ahead and get started. So welcome everyone back to UCSF's Cardiology Grand Rounds. This past weekend, many faculty and fellows were able to attend the ACC conference, which was held in New Orleans this year. And a special shout out to the first year fellows who covered all three sites and held down the fort so that the second year fellows could all attend the conference. Today, we're going to be hearing from the second year fellows about three of the major late-breaking clinical trials that were presented at the conference. Each trial is going to be presented over the course of about 10-15 minutes. And then following each presentation, we'll have about a 5-minute discussion. So first off, we have Dr. Luisa Ciofo and Dr. Colette DeJong presenting on the TriLuminate trial, looking at the efficacy of tricuspid edge-to-edge repair. Dr. Ciofo completed her residency at the University of New Mexico, and she is pursuing a career in advanced cardiac imaging. Dr. DeJong completed her residency here at UCSF, where she was also a chief resident, and she is passionate about health services research in general cardiology. I'll hand it over to you two.
Thank you, Layla. Thank you. Hi, everyone. So today, Colette and I is going to briefly present the TriLuminate trial, which was presented in ACC at Saturday. Colette, could we go to the next slide, please? So briefly as a background, we know that tricuspid regurgitation is associated with heart failure symptoms, multiple hospitalizations for heart failure decompensation, eventually in the end stage is associated with end-stage liver disease, end-stage renal disease. Per guidelines as of now, surgical treatment for isolated TR, it's usually it's a class 1 indication only if the patient is already undergoing a left side procedures such as aortic valve procedures or mitral valve procedures. Next slide, Colette, please. So there is prior studies, small cohort studies that has been showing that tricuspid valve intervention reduce TR symptoms, and in some small data showing that decreases the amount of hospitalizations for heart failure. However, the efficacy in head-to-head compared to medical therapy is still unknown. So with that, just going to briefly go over the design and methods of this study. So the TriLuminate trial was designed to compare tricuspid valve intervention with medical therapy. It was published in New England last Saturday. It was an open-label, prospective, randomized trial compare TEER versus standard medical therapy for patients with TR and New York Heart Association 2-4 with symptoms. It was funded by Abbott, and it included 65 centers across the US, Canada, and Europe. So briefly about the procedure itself. So initially in the first 1/3 of the trial, they used the first generation of the TriClip. And then for the last 2/3 of the trial, they used the new generation of the tricuspid valve device. So, and then the patient was randomized. So once they were selected to be enrolled in the trial, they have up to 14 days to have the procedure done. The population, so anyone who had like severe TR was included in this study and has the New York Heart Association between 1-4 with symptoms. In order to be enrolled in the trial, though, the echo needed to be revised by an independent echo core lab to agree with the initial reading of the echo that the patient had at least severe TR. So they roughly 1,500 patients were screened and consented. And inclusion criteria, as I mentioned before, New York Heart Association between 2 and 4. Patients should have at least intermediate surgical risk. That was defined by the heart team that was part of the study. Pulmonary artery systolic pressure should be less than 70 by right heart cath, and the patient should be already in stable doses of GGMT for at least 30 days. And patients also should have no other indication for surgery. For instance, if you have severe AS, those patients should not be included in the study. They would go for the open heart surgery. And as I mentioned before, all the patients had the right heart cath to evaluate for volume status, those of if the dose of diuretics that they were taking were appropriate, and also to estimate the pulmonary systolic pressure. Next slide, please. So pretty briefly here, I took this slide from the presentation itself from ACC. So let's suppose a general cardiologist select a patient that they thought that would be a good candidate for this patient, symptomatic patient with severe TR. So this patient would go over the exclusion criteria. Let's suppose that they did not have any exclusion criteria. So what would happen is the echo of that patient would be sent to the echo core lab. The echo core lab would confirm that the reading is correct. The patient has severe to torrential TR. And then if that's the case, then the patient would go over an eligibility committee that was made of CT surgery, structural cardiology, and general cardiology to evaluate if that valve would be a good valve for the clip. And then if those criteria were fulfilled, then the patient, they would also see if by doing the procedure, there is a higher likelihood of making the TR going from torrential to severe to at least moderate. If the patient fulfills all of that, then they would be randomized in the tricuspid, the clip arm or medical therapy arm. Next slide, Colette. So they did this, Colette's going to go more in details, but it is hierarchical composite primary outcomes of death, any cause of tricuspid valve surgery, hospitalization for heart failure, and improvement in quality of life by the cancer's quality of life score at the 1 year follow-up. And then as a secondary outcomes, they measured three things: the severity of TR by echo, read by the echo core lab, and safety outcomes issues such as mortality and complications after the procedure. And then as another secondary outcomes was a change in the cancer's quality of life score of at least 15 points between the procedure and 1 year follow-up. So the follow-up was in between 1, 6, and 12 months, and they have an echo performed in 1 month and then 12 months. And then the echo core lab would grade the severity of TR between trace to torrential. And then briefly, the results are going to go over just the baseline characteristics. So, briefly, so this is a pretty busy slide. We have the table 1 of the paper, but the mean age was 78, so early population as expected. Roughly 55% were women. 93.9% had functional TR. And most of them actually have massive or torrential TR, 70%. 90% had atrial fibrillation, 15% had a history of pacemaker or ICG, so probably contributing to the TR. And 25% of the patients only 25% of the patients had at least one hospitalization for heart failure in the past 1 year prior to the trial. With that, I'm gonna let Colette finish the sharing with us the results of the trial.
Hi, everyone. Thank you so much again to everyone who made it possible for us to attend ACC, which was a really wonderful experience. So my name is Colette. I'm one of the second-year fellows, and I'm going to be talking a little bit more about the results. So thank you, Louisa. So in terms of safety and procedural outcomes, overall, there were good safety outcomes of the TriClip. Of the 175 patients randomized to the tier group, 3 withdrew their consent, 172 had the procedure attempted, and 170 had the device successfully implanted. The device does allow for multiple clips, and in fact, the median number of clips was 2.2 in the trial, and people on average left the hospital just a day later. 3 patients had a major adverse event within 30 days, 2 with renal failure and 1 with a cardiac death after another hospital admission that was determined to be unrelated to the device. There was single leaflet attachment in 7% of patients, but no device embolization or thrombosis. 8 patients had an elevated mean gradient across the tricuspid valve of at least 5, but the clinical significance of this was unclear, and they didn't note specific symptoms in this of tricuspid stenosis. At 30 days, 1 patient went to tricuspid valve surgery, and 3 had to have a repeat tricuspid intervention, such as additional clipping for residual severe TR. And at 1 year, 3 TR patients underwent tricuspid surgery compared to 6 in the control group. For example, those that were going to another cardiac surgery and were also going to get tricuspid valve surgical intervention. And 5.2% of patients had major bleeding at 1 year. So I wanted to take a minute and talk about the primary outcome because I'm sure it's familiar to a lot of people in the audience, but I wasn't very familiar with this. It's becoming increasingly used among cardiovascular trials in particular. So the authors use something called the Finkelstein-Schoenfeld method and a win ratio analysis. Effectively, with a win ratio, it's an approach to analyzing a hierarchical primary composite outcome. So effectively, the authors form every possible pairwise combination between the control group and the tier group. So 175 times 174 is over 30,000 pairwise combinations. That's called an unmatched win ratio analysis. And they compare the number of tier patients with a superior outcome to the number of control patients with a superior outcome. The kind of impetus for this is that many cardiovascular trials do have a composite outcome. And you can imagine that when the composite outcome has a kind of priority of clinical importance, from death to hospitalization, for example, in traditional analyses, sometimes whichever part of the primary endpoint is met first is basically the one that is significant in the analysis. So there's a possibility to kind of ignore or devalue fatal or more serious outcomes that occur after an earlier non-fatal outcome that's within the composite outcome. So the win ratio is being increasingly used for hierarchical analyses with composite outcomes. This is from the Abbott Statistical Analysis Plan. I do think it's worth noting that the analysis was done by the sponsor for this trial. So as I mentioned, they used an unmatched win ratio. And so despite the trial being, kind of on the more moderate size of only 300 patients, this analytical approach allowed them to do over 30,000 pairwise kind of matchups. And basically the way it works is that the analysis kind of proceeds stepwise. So, comparing the matched tier patient with the control patient, who experienced mortality first? No one died. Who was hospitalized first? No one was hospitalized. Who had an improvement in the Kansas City cardiomyopathy questionnaire? So in that fashion, with each matchup, they proceed through and see who had the superior outcome overall. So they did meet their primary endpoint, and with this analysis and this hierarchical outcome, tier was superior. So the win ratio was 1.48. There were over 11,000 wins for tier, 7,000 wins for the control, and 11,000 ties, meaning effectively that, for example, none of the outcomes happened in either group, or they were matched. And so this difference was significant with a confidence interval of 1.06 to 2.13. This is broken down by kind of components of the composite endpoint. So here on the left, you see this win ratio that was positive and favored tier. However, what you do see here is that there was no difference in death or tricuspid surgery. There was no difference in heart failure hospitalization. And the difference was completely driven by this change in the Kansas City cardiomyopathy quality of life score. And on this 100-point scale, improvement of at least 15 was considered a positive change. Again, in the individual component analysis, you can see there was no significant difference in mortality, surgery, or heart failure hospitalization. And these slides are from the ACC presentation. The average KCCQ score at baseline was 55. It was 54 in COAPT, so kind of a comparable patient population with a fair amount of symptom burden at baseline. Another way of looking at these results is that you'd have to treat 4 or 5 patients with TriClip to achieve an improved KCCQ in one patient. The average improvement across all tier was 12.3 in the 100-point quality of life scale. And actually, there was improvement in the control group as well of 1 point. About a quarter of patients had good or excellent quality of life at baseline. Before I move on to the next slide, we'll talk about this more at the end, but I think it's really important to highlight that this was a open label and unblinded trial. And so improvement in a patient-reported quality of life score in the context of an unblinded study where people have undergone an invasive procedure with a hospitalization, I think is something that we have to approach with kind of some criticism or some hesitation. So this is showing the severity of TR on echo at 30 days. The TriClip was successful at significantly reducing TR in patients, and the benefit was sustained really markedly well at 1 year. So after the TriClipping, 87% of patients in the tier group had moderate or less TR compared to 4% in the control group. If you look at it the other way, about 50% of patients still had moderate TR after clipping, moderate or worse TR after clipping. So discussion. So the conclusions were that among these 350 patients with severe TR, this was the first randomized trial of its kind to examine the safety and efficacy of tricuspid clip in this population, which is a sick population with a lot of symptom burden. TR was safe, and there was a positive primary hierarchical composite endpoint, which was driven by this improvement in the quality of life questionnaire. There was no difference in mortality or hospitalization. The authors commented that overall, the rate of hospitalization and mortality was lower than they had predicted. And these patients will be followed for 5 years. And there was a significant reduction in severe TR by echo at 30 days, which was sustained at 1 year. So caveats and limitations. I'm really excited to hear thoughts from the group about this kind of unmatched win ratio approach, which I think has its pros and cons. It seems like on the one hand, it has some elegant ways to prioritize more serious clinical outcomes in a composite endpoint. However, it also means that something like just self-reported change in the Kansas City cardiomyopathy questionnaire, which normally you wouldn't think as making it into a primary composite endpoint of a clinical trial, was part of the primary endpoint, and in fact is what drove the positive results of this trial. And if a 6-minute walk test or some other measure of functional status was instead used, the trial would have been negative. Similarly, the TR severity was unblinded, and 50% in the tier group still had at least moderate TR. One thing that I am interested to hear the thoughts of the group is that in clinical fellowship, the times that we've gotten consulted about severe TR and seeing really bad outcomes from severe TR, it's often talking to the KTU team or the LTU team, and patients with very, very advanced liver or renal dysfunction, mediated in large part by their TR. And so I don't know if the trialists, what the discussion was around, could there be any kind of renal or hepatic endpoints, or whether that's something they're going to be looking at in the 5-year study, whether there's any prevention of end-stage liver or renal failure. That's something I think would be interesting. TriClip is already approved in more than 50 countries, and I suspect that application is in process in the US. And of course, at UCSF, including on this call, there's already a lot of clinical experience with use of the MitraClip in tricuspid position, which is also by Abbott. So at that juncture, I'm going to stop. I know we have a lot of very experienced folks in the audience and would love to hear thoughts and questions. Oh, Nora asked a great, or Dr. Goldschlager asked a great question in the chat, GDMT and TR. It's a good point. I mean, I think the main thing they were looking at on the right heart cath was the patient sufficiently diuresed? Other than that, you know, in these patients with only mild RV dysfunction, I don't know if there was a lot of standardized medical therapy.
Yeah.
Looks like you have a couple of questions, Colette. So Dr. Omaria, you raised your hand.
Yeah, I mean, there's a lot, I think, to take from this analysis, and it's certainly a little bit, I would say, just overarching concern as the results are certainly not as robust as many of us had hoped. I think all of the points that you've raised are very good ones, and we can certainly go through each one. The primary one that I think you've perhaps mentioned that is highly relevant and I think worth considering is what is the validity of using a patient-reported outcome in a procedure that is not blinded. There was not a sham arm, for example, and that I think is a relevant point. I would believe, you know, in delving into this in a little bit more detail, the only thing that I can find that perhaps argues against the result being a placebo effect is the fact that there was a direct and relatively strong correlation between the magnitude of TR improvement and the magnitude of KCCQ improvement. So it does suggest that there is, in fact, a direct relationship there. And certainly, while there may be some degree of quote unquote placebo effect, it's hard for me to believe that the patients would have some sense of the magnitude of improvement of their TR, although I guess it's possible. But regardless, I think that is a concern. In regards to other shortcomings with this device and this trial, I think, first of all, the fact that they started the trial with not utilizing the G4, I think the older generation MitraClip is in fact a limited device that I think, especially in the tricuspid position, is suboptimal. Being able to grasp leaflets independently is a very big deal when you're dealing with TR, given the size of the coaptation gaps that we often find. So that, of course, is one. The other is the fact that 25% of patients had excellent quality of life at baseline. It's not clear to me what they were trying to make better in patients like that. So why in the world were those patients even included? And so one could argue that we need to do a much better job, or these sites needed to do a much better job in regards to patient selection. Having said all of that, the proportion of patients with moderate or less TR is robust. They were able to effectively reduce the TR. And again, there was no change in heart failure hospitalization or mortality. And the one final point I'll make is that it is very perplexing that there is such a disconnect between heart failure hospitalization and quality of life, because people who are hospitalized do not have a good quality of life. And so the fact that you have such a robust improvement in quality of life, but yet arguably even greater hospitalizations in the patients that receive the procedure is, again, something that is very concerning. I don't know if that relates to residual TR. I don't know if it relates perhaps to the tricuspid valve gradient that was present in a subset of the patients. Certainly with this device, the fact that they were putting in some patients as many as 3 or 4 clips certainly increases the risk of inducing tricuspid stenosis, which is, of course, something that we are not as familiar with in the clinical setting. And so I wonder if some of those patients actually had worsened symptoms largely because of that. The final thing I will mention is that we do have 2 ongoing trials. They're competing trials that we are a part of here at UCSF. One is the CLASP 2 TR trial, which also is an edge-to-edge repair procedure, but it utilizes a different device, one made by Edwards Life Sciences, the Pascal device that has already been FDA approved for primary MR in high-risk patients, but it does allow you to independently grasp and has some features that may be less prone to traumatizing the valve tissue, which I think is an important point in TR. We also have the TRISCEND-2 trial, which is a transcatheter tricuspid valve replacement device utilizing the Edwards Life Sciences Evoke valve. And I will say that many of us in the community are starting to wonder if replacement is going to be the way to go, given the somewhat underwhelming result of this trial. But I think a lot still to be learned. A lot of other analyses are, of course, planned with this data. And, we'll see. We still have a lot to learn with TR.
Thanks. Those are all great points. Dr. Redberg, you had raised your hand as well.
Thanks so much. And first, Louisa and Colette, great job on this presentation, and also great job on your posters at ACC. That was awesome. I agree with all of the points that Sammy made, as well as you made during your presentation. I did just want to highlight a few things. As Colette mentioned, it wasn't just that the sponsor, did the data analyses. I mean, the sponsor participated in site selection, trial management, data collection, data analysis, and improved the final paper. And also did the adjudication, so that death that occurred was adjudicated by the sponsor, who was highly conflicted that it wasn't related to the device. I would say that remains open to question. But in general, as Sammy said, I see absolutely no reason this was not a sham control trial. And the fact that it wasn't, and it is totally riding on KCCQ, I think makes it unethical, because these people have undergone a procedure and we don't have an answer. We have no idea whether this was all placebo effect, and it certainly suggests that. The only other point about KCCQ is that it doesn't even budge quality of life. I mean, it's an issue when we get papers at JAMA Internal Medicine with KCCQ, because it's such a small part of quality of life that your overall quality of life can go down and your KCCQ can come up. But the real problem is just you do a procedure, you tell people they're better, and then the only thing that changed was that they said they were better in that. And Colette, I don't think it's just you. I think most of us are not familiar with the win ratio. I had to ask around, and nobody in my immediate group at ACC knew it, so I had to go to the statistical experts. So I thought Sammy's comments about additional data are really important. I hope that the other trials we're doing are sham controls and blinded, because obviously the echo readers are not blinded either. They see the clip.
And then Dr. Marcus, you had raised your hand as well.
Yes, thanks. And again, agree. Fantastic presentation. I had a comment and a question. The comment is about the hierarchical outcome and the win ratio. And just to mention, as you all think about research questions, one of the great applications of it, or promising applications, is if you have an exposure where the hypothesis really could support either a benefit or harm, or kind of pleiotropic effects. So we proposed using this in a major study of daily alcohol versus abstinence, where, well, maybe that's going to reduce MI, but it's going to increase AFib and heart failure. And how do you kind of compose that all together? And so that's a particular, I think, useful application to this new method. The other, and Colette did a really outstanding job describing this very complex sort of analysis. The other theoretical advantage is that everyone can contribute to the outcome. So it's not, so by using quality of life scores, for example, although in this case, they kind of dichotomized it rather than using it continuously, understanding there's the downside of those things get soft over time. My question has to do with what they did with the implantable devices. And when I saw the paper, I'm always curious about this. And because it gets pretty complicated pretty fast, and I see Byron's here, and Sammy may be able to address this. So options are they extracted all those devices because they're tethering the tricuspid valve, but then you have to reimplant in the setting of this clip, or put in an epicardial device, put in a lead in a coronary sinus. That, you know, it becomes a pretty big deal pretty quickly. And it wasn't clear to me on my admittedly cursory review of the paper that there was a protocolized way to deal with that. So curious if you guys were able to suss that out.
I think answer that. With edge-to-edge repair, we make no consideration for pacer leads, and essentially you work around it.
Okay, and they're not so fibrotically tethered that it you can still grab something.
You can usually grab, but it really depends on where the leak is and where the regurgitant jet originates relative to the lead. If it is truly around the lead, those are patients that honestly are not well suited for edge-to-edge repair because you're not going to be able to get the actual main area of the jet. If, on the other hand, let's say you have a lead nicely tucked within the posterior commissure, the posteroccipital commissure, and the jet is more anterior, that is something that is much more easily amenable. So as long as the primary focus of the jet is far away from the lead or far enough away to allow you to treat it, then we just leave it in place.
So presumably those folks were excluded in determining the suitability.
Correct.
Got
It's
it.
a much more controversial topic, and there's actually moderated a debate at ACC about replacement. When we put an evoke valve in as part of the transcatheter replacement trial, the practice has been to jail those leads, which again is controversial. I know my EP colleagues probably do not think that that is wise. Having said that, the trial allows it. The surgeons often say, well, if something gets infected, you're going to take the valve out anyway. So they don't really push for us to extract leads. But I think those decisions need to be made on a case-by-case basis.
Can I raise another question related to rhythm and need for devices? And that's 90% of this group had atrial fib. And we don't know what happened with them or to them, or they cardioverted, because it's sounding like an ablative procedure, for example, would not be allowable in such patients. Do we know, Colette or anybody, do we know what happened to the fibrillators? Were they left in fib? Were they cardioverted? Did the procedure make any difference relative to controls?
I don't think we have those outcomes. If the procedure improved AFib, specifically, they did not aim to do like rhythm control versus rate control strategy. They were more like focused on the hemodynamics, like in the right heart cath. If the filling pressures were in the reasonable range, they would pursue, but they were not like focused on rhythm versus rate control. It was at discretion of the primary cardiologist of how to manage those.
So to Greg, for example, would ablation be prohibited in these patients? AF ablation?
I don't think so. You
You
mean separate from the trial design, just clinically?
If you do anything to the tricuspid of this nature.
No. You could still ablate them. With the success of the procedure, that's another question, but there's nothing mechanically to preclude doing it.
Yeah, I think that's the major question in my mind, because most of these patients, given the fact that they have such severe tricuspid regurgitation due to annular dilatation, I suspect a lot of them have been in permanent AFib for quite a long time. And I would defer to our EP colleagues as to whether they would expect that ablation would be successful in that sort of setting. But it's a great point. And I think I must admit, I am shocked by how common AFib seems to be in this cohort. I can tell you in all of the transcatheter trials, the prevalence of AFib approaches 90%.
Well, and Elise Foster used to always make the point that the AFib might contribute to the TR. So there's definitely chicken and egg. So that fixing the TR could actually enhance your success of the ablation. The ablation could also reduce the TR, theoretically.
Yep, absolutely.
All right. Well, thanks so much, Colette and Luisa, for sharing the results of the TriLuminate trial. That was a fantastic presentation. We're going to move on to the next trial. We have two more to go through. So we have Dr. Shannon Walker, who will be presenting the BMAD trial, which is looking at a wearable device for improving heart failure readmission rates. Dr. Walker completed her residency and chief residency at Johns Hopkins University. She is passionate about leading efforts to ensure the equitable distribution of resources, both globally and locally, in general cardiology care. Shannon, take it away.
Okay, hello everyone. We'll be shifting gears just a little bit, and since we have two more cases to go through, I'll do mine a little bit faster, but I want everyone to think about what they're eating for lunch right now, and for a little bit of audience participation, if you feel like you want to share in the chat, you can write what you're eating. I see Dr. Redberg on here, since you walk 11 flights of stairs each day. I'm sure you're eating something healthy. Robert Malloy says poke bowl. Byron Lee, panda. Oh, that can't be healthy. Atif says tuna salad. So I'm going to talk about what should we be eating for lunch. I actually did one of the clinical research projects, not one of the trials, but the question that we're going to discuss is to keto or not to keto. This was the presentation that I'm basing my project off. And basically, this is our patient right here. So someone who's lost 80 some pounds, maybe they're diabetic, overweight, they've been following a keto diet, but is it really all just hype? I have no disclosures other than the fact that we had a short turnaround time for these presentations. So I stole most of my slides from the original investigator. But this is the main premise. 15% of Americans, Canadians follow low carb or a keto diet. We've seen that keto is effective for weight loss and lowering A1C, but it can cause lipid levels to increase. So the central question they thought to ask is this keto diet and lipid increase associated with increased MACE, despite the possible benefits of weight loss or glycemic control? So their primary endpoints, and I'll go through the study design in a second, were to determine whether a low carb diet and the impact that had on serum lipid levels. And their secondary endpoint was to investigate whether there is association between the low carb diet patterns and major adverse cardiovascular events in a population-based cohort. So in the UK Biobank, they took patients from there. It's a population-based cohort study with over 1 million participants, usually between 40 to 70 years old, mainly white, mainly European, mainly healthy. So that's where they drew their patients from. And then they gave each of them a diet survey to describe the food that they had eaten in the past 24 hours, the food and beverages on a validated diet survey. And then they took a number of labs, mainly lipids, ApoB, and some other ones, which we'll go over. And then they divided patients based on their diet survey into a standard diet group or a low carb group. This is something that they showed in the presentation just to distinguish that. And what they looked at for low carb was carbohydrates that were less than 25% of the total daily energy intake, which is actually different than keto. Keto is technically supposed to be less than 10% of carbs, but they stuck with this low carb diet. This is how they enrolled their participants. So like I said, the UK Biobank is almost 500,000 people. Within those, some of those had initially completed a dietary survey at that visit. So from those who completed the dietary survey and at that same point in time had lipids, blood testing done for lipid availability, they looked at those and ended up getting about 60,000 participants, which for whom they had their information on. And then they divided it into patients with a standard diet and then a low carb diet. They ended up having about 300 in their low carb diet group and about 1,200 in their standard diet group. And those were matched. And they also subdivided it between those who were on lipid lowering therapy. These were the baseline characteristics. So interestingly, some things to note, 73% were female in the group. The average age was in the 50s. 90% were white. They had, within both groups, it was the same household income, education, and levels of physical activity. There were more people, as you would possibly expect, more people in the low carb group who had diabetes or obesity, and presumably they were choosing this diet to lower their risk. And then the risk factors for smoking and past medical history, past other history were the same. So when they looked actually at the people in the standard diet group or the low carb diet group, this is kind of what comprised the diets. I'll just let you read this, but obviously in the low carb diet group, there are actually fewer calories, lower carbs, more fat, more protein. A lot of this was animal fat and protein. There's also more cholesterol, more saturated fat. And they had blood testing for ketones, and they confirmed that patients were actually in ketosis. So the way you can kind of remember this in your head is over here, you've got Dr. Sean Lee following his ketogenic diet. And this is the second year's class, lovable baby Advaith, following his mainly plant-based diet. And I just want to sidebar real quick and just say that at UCSF, we actually accept all diets from our faculty and fellows. You can potentially do the liquid diet seen by Allison and James here, or the soup diet by Louisa and James's partner. Here's Dr. Schiller with his poke bowl at the VA, or Anna Bayer actually supplied a very healthy delicacy diet to all the women in cardiology at an event that she hosted at her house. So there are no judgment for any of these diets that you may choose. When they looked at these diets compared and with the lipid levels, they basically found, as you would expect, higher LDL, higher apolipoprotein B in the low carb group. And when they looked and these numbers, just FYI, are in the European numbers, but at the bottom, I use like a calculator. So like 3.8 is in the 140s for LDL. So they're actually kind of similar here, even though statistically significant. And when they looked at the highest, the patients who had the highest amounts of LDL, there was actually more of a difference in the low carb group once you get up to an LDL over 190, and once you get to higher apolipoprotein B compared to in the standard group. So I think they showed somewhat effectively that low carb diets lead to increased lipids. So then when they asked the question of how is this associated with MACE? And remember, this is just an observational study, so it's only associations, but over an almost 12-year period, they basically found that patients with the low carb diet actually had a higher incidence of CVD events. And even with Cox regression analysis to get rid of the confounding variables of diabetes or smoking or hypertension, they actually found that the hazard ratio was significantly elevated. And so you can see that over time, the risk widens here. And then this just shows that for patients with, so an LDL over 5, that's basically over 190s, that patients with the highest LDLs actually had the most amount of risk compared to standard diet. This is interesting. So it's a low carb diet with an LDL over 190. This is a standard diet with an LDL over 190, but it was actually still higher in the low carb diet. So then you might ask when I was watching this, I was asking myself the question of like, okay, is this just because in the low carb diet group, these are people who maybe have diabetes and they're overweight, and that's actually what's causing an increased MACE, not necessarily the low carb diet, but they actually excluded at one point in analysis, excluded patients with diabetes. And when they compared those two groups, they still found that patients with the low carb diet had an increased hazard ratio for ASCVD events. And then found that in patients, this is just looking at low carb versus very, very strict low carb diets, there was even more of a risk there. So just briefly, and then I would love to hear some feedback on what others think about this study, but some limitations is obviously it's just an observational trial, so you can't determine anything causal. It's just self-reported data, so people actually just had to write what they had eaten for 24 hours, relatively small sample size. It's a very homogeneous population. One of the questions that came up after the talk was, this was a one-time questionnaire of what are people eating, and they were followed for 12 years. So how many people did actually follow that diet? And then one of my questions was, whether people were really trying to maintain a keto diet or if people just happened to eat a lot of meat and that put them at risk. So overall, these are my conclusions, and I'm curious what maybe some of the preventive specialists or other people who think about this in the audience would think. But I think the study shows that keto diet is associated with increased LDL, ApoB, and increased incidence of MACE. So I think for our patients electing keto diet, we should monitor their risk factors carefully, monitor their cholesterol levels carefully, and potentially, encourage them to do more plant-based fats. My mom, who likes to do a lot of research on this, has recently told me about the Ketoranian diet, which is eating a lot of plants with some fats and proteins. And so that might gain traction moving forward. So thanks to everyone, and curious to hear some thoughts from the audience.
That was a very nice summary of the data and presentation. I guess I'll talk about it since I spent a lot of time thinking about the UK Biobank. I think it's very difficult to get excited about studies that are non-causal in nature and that basically condition on the outcome of disease processes. Like there's no reason to think that people were randomly allocated to their diet. And so, sure, they showed some sensitivity analyses that sort of demonstrate that the results can't be fully explained by weight or a couple other risk factors, but I don't think that there's any way to really control for the type of things that cause you to have a particular diet. So it's not super surprising to see the results that they found, but I don't know what to take away from it.
Thanks, James, for sharing. Any other opinions or thoughts? I know it's very limited by the fact that it's just an observational study.
Hey, Shannon, this is Jackie. I was just going to say, in the subgroup that had the high LDL cholesterol and on the keto diet, that hazard ratio of 6.6, I just feel like I know you can't draw causal inference from an observational study, but that's such a high hazard ratio. It was one of the things I took away, that the fact that some unmeasured confounder that they're not accounting for, which they accounted for diabetes and BMI and some of the classic cardiovascular risk factors, could establish that high of a hazard ratio, makes me think that there is some type of causal inference that could be obtained, although obviously with the limitations of an observational study. That was my only one thought.
Then it looks like Dr. Marcus put a question in the chat. Did they look at changes in weight? Oh, okay. And Shannon, you responded that it does not look like they did. All right. Other questions about this presentation in particular? Shannon, you did a great job in presenting it. And I love that everyone shared their own diets. If not, we'll move on to the last final presentation for today. So we have Dr. Sean Lee and Dr. Allison Kratka, who will be presenting results from the CLEAR trial, which looked at the effects of bempedoic acid in cholesterol reduction. Dr. Lee earned his MBA degree in addition to a medical degree at Dartmouth. He completed his residency at MGH before joining fellowship here. He is committed to developing novel therapies to cure heart disease in the future. Dr. Kratka completed her residency at Brigham and Women's Hospital, and she is interested in payment reform research. She will be pursuing a career in structural echocardiography. I'll hand it over to you guys.
All right, thanks, Layla. We'll try to move somewhat quickly too. So I'm going to start. So we're going to talk about the CLEAR outcomes trial, or bempedoic acid and cardiovascular outcomes in statin intolerant patients. So for the background, what is bempedoic acid? So it's an inhibitor of ACL, or ATP citrate lyase, which you can see on the image on the right, that targets cholesterol synthesis upstream of HMG-CoA reductase, or what statins target. So it is a prodrug. It's activated by very long chain acyl-CoA synthase 1, or ACSVL1, which we can see on there, which is present in hepatocytes, but not in skeletal muscle. And so the hypothesis with this drug was in patients who are statin intolerant, presumably due to myopathy, although that can be debated, that they would not have similar issues with this medication. So the drug reduces hepatic cholesterol synthesis and raises LDL receptor expression, therefore increasing the clearance of LDL cholesterol from the circulation. So what is the trial rationale? So 7 to 29% of patients report adverse musculoskeletal effects that prevent them from taking statins. And prior studies have demonstrated efficacy of bempedoic acid in lowering LDL cholesterol. So that trial was a phase 2 dose escalation trial published in 2013. The results shown on the right here that showed a significant reduction in LDL with bempedoic acid. The max dose given there was 120 milligrams, but they did not look for clinical outcomes of bempedoic acid. So this was a little bit of proof of concept, but no clinical outcomes. So the methods for this trial, the patients included were 18 to 85 years old. It was double-blinded, randomized, placebo-controlled, and patients had to have either of two, a prior cardiovascular event, so secondary prevention, or clinical features of high risk for an event or primary prevention. They had to report being unable or unwilling to receive statins. They were allowed to be receiving other cholesterol lowering therapies such as ezetimibe and PCSK9 inhibitors. And the trial was performed at 1,250 sites in 32 countries. And we can skip this for time. But basically there were 22,000 patients screened and we ended up with 6,500 in each group. So in order to be included, as I mentioned, they were primary and secondary prevention patients. Their LDL-C had to be over 100, and they were randomized to either get bempedoic acid 180 daily or matching placebo. To meet criteria for statin intolerance, they had to sign this written form that basically said that they can't tolerate these medicines, even though they know that they're, life-saving, and providers also had to sign a similar form. As far as the statistics, it was designed for 90% power to detect a 15% reduction in the primary outcome. And over 24 months of follow-up for 90% power, they determined that they needed 1,620 primary endpoints and 800 secondary endpoints. And assuming a 3.5% annual event rate, they calculated ultimately a need for 14,000 patients to be included. So the primary endpoint was a 4-component MACE, cardiovascular death, non-fatal MI, non-fatal stroke, or revasc. And the secondary endpoints tested in hierarchical order are seen here: 3-component MACE, fatal or non-fatal MI, revasc, stroke, death, cardiovascular death, and all-cause death. So as far as the patient characteristics, notably, there were a lot of women relative to other cardiovascular trials. Everyone at ACC was really excited about that, as are we, 48% women. And there was a large percentage of patients with diabetes. And then otherwise, these characteristics were similar between the two groups. Looking at lipid modifying therapy at baseline, this is just notable for the fact that the placebo group had significantly more lipid lowering therapy on board at baseline than the bempedoic acid group. And then kind of not shown on this slide, but just one kind of point about the patient characteristics as well is that discontinuation of the regimen was actually similar between the two groups at 30% in both groups, and that included the placebo. And that was due to what patients thought were intolerable side effects. So I'm going to turn it over to Sean to talk about the results and discussion.
Great, thanks, Allison. Moving on to the results of the trial, first of all, we see, as previously confirmed, that bempedoic acid is a potent agent in terms of reduction of LDL over time, as we see in this left graph here, with placebo being on top and bempedoic acid being on the bottom. Interestingly, the placebo arm had sort of, as the trial progressed, greater and greater reduction of their LDL levels, presumably because they were on more lipid modifying therapies other than bempedoic acid. The authors also highlight that bempedoic acid is a potent agent when it comes to reduction in high sensitivity CRP as a biomarker of inflammation, and inflammation is being sort of more front of mind for clinicians now as a risk factor for cardiovascular disease. In terms of the primary endpoint, the trial met the 4-component MACE with a hazard ratio of 0.87 and a p-value of 0.004. with an absolute risk reduction of 1.6% and a number needed to treat of 63. When we take out coronary revascularization in the 3-component MACE, the trial continued to be statistically significant in meeting that endpoint as well. And as we approach the secondary endpoints, like Allison said, these were tested in a hierarchical fashion. So as long as the endpoint was met, the endpoint after would be tested. So we showed that bempedoic acid was significant in reducing fatal and non-fatal MIs. It was significant in reducing coronary revascularizations. However, it did not have an impact on cardiovascular death or all-cause mortality. With regards to safety, which arguably is just as important for this trial as the efficacy standpoint, we see that there is numerical equivalency between the serious treatment adverse effects between bempedoic acid and placebo. Similar rate of adverse event leading to drug discontinuation. Reassuringly, any muscle disorder was similar between the two groups. There was a slight numerical increase in elevated hepatic enzymes, pre-specified renal events, and specific to bempedoic acid, gout and cholelithiasis, and this is thought to be due to off-target effects of bempedoic acid being a weak inhibitor of the organic anion transporter 2, O2, which is expressed in the kidneys, which impairs renal excretion of uric acid. In the supplemental data, the authors did some predefined subgroup analysis, and one of the things that was discussed during the meeting was it appears for some reason that bempedoic acid had a bigger treatment effect for the primary prevention group rather than the secondary prevention group. There could be a variety of explanations ranging from sort of within the possibility of a type 1 error and statistical measurement. Other possibilities include perhaps the patients who were enrolled, who were primary prevention, were actually at the higher end of cardiovascular risk, thus magnifying the treatment effect of a lipid-lowering therapy. So the trialists conclude that bempedoic acid was efficacious in lowering both LDL and high-sensitivity CRP. The top-line result was that bempedoic acid lowered the risk of the primary endpoint, which is a 4-component MACE, by 13% compared to placebo. And lastly, bempedoic acid was generally well tolerated with no difference in musculoskeletal side effects and a small increase in the risk of gout and cholelithiasis. In dissecting this trial, we first say that the treatment effect of what we see in this trial is believable. It's plausible because of the reduction in the degree of LDL matches what we see in the clinical outcome when we aggregate prior statin trials. When we look at the efficacy, I think a couple of questions arise. First, given the potent reduction of high-sensitivity CRP, is the risk reduction of the primary endpoint due to LDL lowering, or is actually reducing the residual inflammatory risk? Most likely a combination of both. Some discussion were had comparing the treatment effect of bempedoic acid to the prior PCSK9 trials. And it's really hard to compare because in this trial, the patients were on bempedoic acid and were nothing essentially. Very few people were on ezetimibe or statins, whereas the PCSK9 trials were added on top of high-intensity statins. I think the authors highlight potentially an opportunity for bempedoic acid to be used in primary prevention. I think lastly, for me, looking at sort of the landscape of statin alternatives, especially there was another trial presented at ACC where they showcased Merck's phase 2 data for oral PCSK9. I think in terms of efficacy, bempedoic acid is up against some pretty stiff competition in terms of statin alternatives. In terms of safety, I think the fact that we didn't see a difference in the MSK safety endpoints congruent with sort of the bempedoic acid mechanism of action being a prodrug with the activating enzyme not present in skeletal muscles. Furthermore, it is reassured that in this pivotal phase 3 trial, we did not see an increased risk of tendinopathy that potentially was seen in the phase 2 trial. I think ultimately the million-dollar question in terms of how we interpret this trial and how it will impact clinical care is how do we think patients will weigh the side effect profiles of bempedoic acid against those of statins? Because while it ameliorates potentially some concern about the MSK side effects, there are some unique side effects of bempedoic acid like gout and cholelithiasis that we have to communicate to our patients. And those are our thoughts on this, this trial.
Thanks, guys. Yeah, open to the audience for any questions or thoughts folks may have. I had a question, which was just the no difference in mortality. Do you think that was just because the follow-up was relatively short, or was there something else to it?
Yeah, I think it's a combination of many things, right? So the mortality endpoint for these modern trials, right, with good medical therapy, other than just lipid-lowering therapy, you probably have to, the actual treatment effect is probably small. So you need a bigger study population followed for a longer period of time.
Yeah, makes sense. All right, we have a couple questions. So Dr. Long says 30% discontinuation in the active treatment group exceeds that for most statin trials. What about telling patients that nearly a third had stopped the drug? Yeah, I mean, I agree. I think that 30%, that number in itself it seems a little high. And then Dr. Redberg says about none of the primary prevention lipid lowering trials show benefit on mortality. For example, PCSK9 had increased CV mortality and no benefit on all cause. So comparable to other LDL lowering therapies. That's good to know.
And
Yeah,
I just
think
would
those are-
add, Layla, the caution on that discontinuation statistic is a lot of the statin trials do a run-in period. And so they basically take out everyone who had side effects during the run-in. So it's really hard to compare. I didn't hear a run-in period for this drug trial. So
I think there was, right, Sean and Allison, like they had to take something for a month to just prove that they were able to take medicines. Although I forget exactly, I think it was a statin medication, but I'd have to double check that. But there was some.
But it would have to be this drug, right?
Yeah.
They do in the statin trials.
Mm-hmm. I see. So they were giving in the statin trials, everybody the statin, the treatment arm. So you're saying that they would be giving bempedoic acid in this case.
Right. That's what's called the run-in period. Unless you take out people who don't tolerate the drug.
Yeah, Layla, you're right. This trial did have a month-long run-in they all just took placebo for a month. And then they excluded people who felt that the placebo had an intolerable side effect.
What was that number?
It was, let me look.
But that's interesting. That controls more than just for the ability to take something regularly rather than the medicine itself and intolerability of the medicine.
Yes, they're trying to get rid of people that would have a side effect from anything they took, right?
And to answer your question, Dr. Long, so they initially screened 22,000 people. 14,000 of those met like criteria. And then, of the 22,000 people screened, 205 could not adhere during the run-in. So it's a pretty small percentage. That's like over in that far right box. I just thought it was also interesting to that point that 30% of people in placebo discontinued it because obviously they weren't having any actual side effects. So I think that does speak strongly to like the nocebo effect as well.
I mean, I always harken back to what Noelle says when I asked her once about, what do you do with people when they just say they're not going to take the statin, and they have these, she says, I don't argue with them anymore. I just say, I'm really sorry you're not able to take this life-saving medication. And then she moves on. So yeah, I think that those N of 1 trials are quite informative on statins.
All right, well, thanks everybody for attending. Thanks to the second years for those awesome presentations of the clinical trials from ACC. Thanks again to the first years for providing coverage for everyone in the second year class to be able to go, and as well to everyone in attendance for such an enriched discussion. It was really great, and I'll see you all next week.
Thanks.